There we go.
John, my buddy John.
Go ahead.
Today's
Okay, we're ready to call the meeting to order. Roll call.
Everyone was at 8:05.
Okay, approval of the agenda for today's meeting.
So moved.
Make that motion. Okay, Tim, Joanne, second. All in favor, say aye.
Aye.
Opposed? Hearing none, the agenda is approved. Approval of the July 21st minutes.
I make a motion.
Julie, is there a second?
I so second.
No, all in favor, say aye.
Aye.
Opposed? Hearing none, the minutes are approved. Public comment, there is no one from the public here, so we will move on to approval of provider contracts.
I put the sheet in front of you. We have two of them, Kewaunee Health and Fitness, and then the Mightier Inc.
Okay, so we get a motion to approve those. Tim made a motion, is there a second?
I so second.
No second, all in favor, say aye.
Aye.
Opposed? That is approved. Okay, the next thing is unit reports, behavioral health.
Actually, this will work even better.
Otherwise,
Now
I
that I
can
think about it, there was a method to my madness.
Good morning. For those of you who don't know myself, there's a few newer people on here. My name is Sue Norton and I'm the behavioral health manager. So I oversee all the outpatient mental health, alcohol and drug treatment programs, the community support program, the comprehensive community services program, and the crisis program for Kewaunee County. So today I'm going to talk to you a bit about alcohol and drug programs that we have and some of the services we provide and some of the things that we operate and how we operate. Just a quick show of hands. How many of you think that we in Kewaunee County, a small county of roughly 20,000 people, have a drug and alcohol problem?
What was the question?
If you think we have a drug and alcohol problem in Kewaunee County.
Or whether I have a drug and alcohol problem.
You don't think so? Well, I might change your mind, Rose. I may change your mind. Yeah, you're right, right. And if you're, unless you are aware or hear about it, and obviously here we probably know more about it than maybe the average person does, just because of the field that we work in. So the thing with addiction is it does not discriminate. Addiction does not discriminate. It affects the young, the old, the rich, the poor, the highfalutin societies. It affects everyone. And it not only affects an individual, it affects their families, their friends, their loved ones, and the communities as well. Addiction happens in the best of families. So I don't know if you're aware, and I don't need you to, you may know people who experience an addiction. So just to give you some statistics, in the year, and I got these from the Department of Health Services has dashboards that the public can access, that it provides all the data that the county human services agencies throughout the state, we submit data to them on a regular basis. They put together dashboards. A lot of the information that I have gotten is from the dashboards that DHS has put out. So in 2020, Kewaunee County, little Kewaunee County, out of 72 counties in the state of Wisconsin, ranked 33 in the state for alcohol attributable deaths. That's pretty significant. From the time range of 2024 to 2021, we have the Northeast region, which Kewaunee is part of. Our state is broken up with the Department of Health Services into different regions. And in our region, during that time span, there was 171 deaths related to cocaine, 350 deaths related to meth and other stimulant drugs, 808 deaths from opioids, and 242 deaths from heroin alone. It's a lot of death in a small area. Now, yes, there are some other bigger counties that are in the area, but that's still a significant amount of death. And those are the ones that are reported and that end up in the data system. My guess is there probably are others that go unreported or not in the system that would affect the statistics. So in Kewaunee County, we have two different programs that address drug and alcohol use. We have the alcohol and drug abuse program, and then we have the intoxicated driver program. So in the entire county of Kewaunee, we have one person out of all the agencies, that out of everyone, one person that does the treatment for these programs, for both of these programs, and that's Scott Gartsky. So our AODA program, most oftentimes what happens for someone to come into that program, and our numbers in that program are smaller. We usually get referrals from probation and parole. They say, hey, you have to go get an alcohol and drug assessment done. We may get referrals from Child Protective Services. On rare occasion, we get people who say, I think I might have a problem. I need some treatment. That's the program that we just put them in. So when someone gets put into that program, the first thing we do with any of the programs is we determine, do they have a problem? Not everyone that comes in may have a diagnosable problem. Then we determine through an assessment, do they have a problem? What treatment do they need? What's the best modality of treatment, the frequency of treatment? That's all calculated based on the assessment that we complete with them. Then we have the intoxicated driver program. So anyone who is convicted of driving under the influence, that means you're drunk driving or you're drug driving, so you're under the influence of drugs and or alcohol, or both. If you're convicted of that, then you're required to go and have what's called an OWI assessment, operating while intoxicated assessment in your county of residence. So the only assessments we do for this program are Kewaunee County residents. I can tell you in 2020, we had 163 people who had OWI assessment completed. Now, statistically, they say, on average, a drunk driver drives drunk, that's just being drunk, 80 times before their first arrest. So if we have 163 people driving out under the influence that got caught, imagine the frequency at which people are driving in our county under the influence. Now remember, those are only Kewaunee County residents, and this is where I'm going to challenge you, Rose, on do we have a problem? Those are only Kewaunee County residents because we only do those assessments in the county of residence. So some people could say, well, you have people coming up fishing or on vacation. They wouldn't be getting the assessments at our county. They'd be getting the assessments wherever their county of residence would be. So there are different levels of treatment. So they come in, they do the assessment, and then we determine what level of treatment. It could be no treatment. It could have been an isolated incident. Someone got pulled over. Maybe they had a couple drinks at dinner time or whatever. It's determined not a problem. They may not need treatment. Then there's education, which is just some basic programming that talks about the safety and the risks of driving under the influence, and it's some driver safety stuff. Anyone that meets that level of criteria, we refer to NWTC. They have a specified program that we use or that they do with that program. Then there's individual treatment. So the person would come in and meet with Scott, who is our AODA counselor, and they would do individual treatment. There's group treatment. So we have people who come in for individual treatment, but then they also come in weekly for group treatment. So we might have anywhere from, obviously a group has to be 2 or more, to upwards to the maximum we would have in a group would be 8 people at one time. And then there's intensive outpatient treatment. That is more than 9 hours of treatment a week. We once upon a time did do that, but with the numbers of people and with the having only the one staff person, it got to be kind of difficult. So we had to kind of limit what we're offering. So if anyone needs intensive outpatient treatment, which means they're getting 9 or more hours a week of alcohol and drug treatment, then we have to refer them out to some other agency. There are no other agencies in the county that do this service. So that means they're going to go to Green Bay, they may have to go to Manitowoc, they may have to go, likely they will have to go out of county for that, which can be problematic because the populations that we serve are typically either uninsured or they're on Medicaid, And that means that their income is lower, so now they have the expense of having to figure out, how do I work around my work schedule? How do I get to these services that are not local? And then we have what's called residential treatment. That's what I want to highlight today. Residential treatment means that you meet a level of significance in your drug or alcohol use. That means that you need to have 20 hours of treatment or more per week. Or per, so that means you need more than just coming into the office 1 to 4 times a week. That you need to be at a facility where you're going to get treatment throughout your day. They're going to be monitoring you. It's not a locked facility, but they're going to be providing you those services minimally for 28 days. If you would ask those who are involved in providing treatment, best is 90 days. 28 days, you're just touching the surface, and then they're out. So typically, if we refer someone to residential treatment, we like to have them there for at least 90 days. Sometimes they're there more. So this can be a very costly service. So one of the programs that we use, and this, I would say this is probably the average cost. The treatment per day is $275, and then the room and board is $50. So if my math served me correctly, I had, so that would be roughly $330 a day times 30 days, that's $9,900 a month. And if we do a 90-day stay, that's $29,700 for one treatment episode. So when we think about substance use or mental health for that matter, think about it really no different than someone with a chronic disease. So statistically, they have found that relapse for people who have drug and alcohol use or substance use disorders, it really resembles that of someone with a chronic disease such as hypertension or diabetes, where they estimate 40 to 60% of the individuals relapse while in recovery. So you have a diabetic who maybe shouldn't be eating cherry pie, but goes out to a restaurant and they indulge in cherry pie. Is that considered a relapse because their blood sugars go through the roof? No different than someone who has an alcohol use disorder, maybe goes out to dinner and has a drink, that could be considered a relapse. So the probability of having one treatment episode and not needing further is pretty slim. Well, 40 to 60% of the time, they're going to need more than one treatment episode. So it's extremely costly. So who pays for this? Well, some people who have commercial health insurance, meaning non-Medicaid, non-Medicare, their insurances may cover the cost of the treatment part. Or Medicaid, what has recently happened since February 2021, Medicaid has now added that as a service, as a allowable service under their, what they will cover. So they'll cover the treatment costs of that. If someone is uninsured, the county will cover the cost of that treatment. It's really crazy when you think about it. 300 years ago, Benjamin Franklin said an ounce of prevention is worth a pound of cure. It's thinking about, it's taken till 2021 for insurance, primary insurance, to cover the cost of what I would consider to be a basic treatment for a disease. Substance use is it is a disease. It affects your brain. There's physical and psychological properties to it. For that to be on the, and I think I plug this most every time, for that to be not considered the same as someone with diabetes is a shame. So in the long run, that ounce of prevention, me putting that money in to treat someone is in the long run going to save dollars to these insurance companies, because the research and the evidence shows that long-term use of alcohol and drugs has a significant impact on health conditions. There's a significant correlation to future chronic, costly health conditions. So putting in those dollars, and then I think about also when we look at this system as a whole, as I mentioned earlier, addiction affects families. So if I can treat someone or get someone into treatment who maybe is thinking about having kids, I'm gonna wanna get them into treatment and spend that money up front, because if I don't, I know from the research that people who have children who have addiction, those children are likely to develop psychopathology. They're likely to develop pathology and be in the system, meaning the mental health system, which there's a shortage of providers. And I also know from the research that those families could likely end up in Corinne's unit. And then placements for placing children out of the home, to me, are going to be far more costly than what it would be to treat the person with the addiction to begin with. So we will oftentimes want to spend that money up front to save money, and that's just money. That's taking the human component out. These are people. This is someone's son, someone's daughter, someone's brother, sister, grandchild. That's taking the human component out of it. So none of the insurance companies cover the cost of the room and board. So we've been fortunate to have that treatment part covered, which is helpful. But then the burden comes down to the counties. We do have some dollars that we get from our substance abuse block grant dollars that we use to cover some of the costs. And then we had applied for some opioid dollars that had come about where they're covering the cost of the room and board. So I just did the reporting for the first quarter of this year, and we did have one participant that met the criteria for that, so we'll get reimbursed for the dollars that we will have paid out for the room and board costs for that, which is helpful. Anything is helpful. But thinking about it just in the long term, it's really not, sometimes you have to put a little money up front to get the long-term benefits, and then who doesn't want the kids? You know, who doesn't want to be able to live a happy, healthy life? I mean, then the human part comes in as well. So just thinking about some of those decisions. And my last plug is going to be for staff. You know, my primary care provider just tried poaching me because Provea Health can't find a therapist. And it's like, they have wait lists for 8 months at a pop to get someone in, even with the best of health insurance to get someone in. And it's really about, there are very few people, there's a shortage of people in this profession. And there's a shortage, we have one alcohol and drug counselor in the county. If he were to leave, what would we have? We're required to do some things. That means we'd be having to contract this work out to other people. That means it would be costly to the county to have to contract out to these other entities. And just when you're making decisions about taking care of county staff, those are things that I hope and I encourage you to think about as well, because these are the people that keep things running, and these are the people that are going to be providing the services with the hopes of, you know, I mean, it's epidemic. The mental health and substance use problems in this country are epidemic. And if we don't have providers, that means it's going to become more problematic. So, any questions? Yes.
Yes, you spoke about and said that after an incident, they need an assessment. How long is there a time period? They must have this assessment within 24 hours or 48 hours.
A time frame for the alcohol and drug assessment,
Yes.
the OWI assessment.
Well, either of them after the incident or a citation or pulled over by a police officer or authorities or whatever.
So usually there's a court date that's set up. And we have for the OWI, because insurance does not cover an OWI assessment. So there's a $275 fee. We require that fee to be paid upfront before the assessment is scheduled. That's been, since I've been manager, that's been one of the changes that we've made, because otherwise we have people showing up, no money for the assessment, and there's a lot of legwork that gets put into it. So we've kind of made that policy. So it's really on their own. And it's not to say that we're not sympathetic, because sometimes circumstances happen, we can work out things, people can make payments. So a lot of it is really up to them. If we get a referral for it, I can tell you within the week, my staff person is taking all the referrals. I do not have a wait list for the program. He's been able to figure out how to maintain and manage everything that we get. So it could be a couple of weeks, but it's not going to be, as long as they pay their fee, it's not gonna be months.
Okay,
Mm.
another question. Now, what determines the length of the treatment if you have to go in this 28-day or night? How many incidents they've had or through the assessment or?
Well, through the Medicaid benefit, they have to do what's called a prior authorization for the service, so there's, it's called the ASAM, and that's a whole form of assessment that's used to determine that level of care. And then every so many weeks, they have to show progress and show where they're going to be able to get that approved. So it's not just an automatic, oh, you're gonna be there for 90 days. As long as they're making the progress and they're able to show that to the insurance companies to pay, roughly, like, the goal is to get them to 90 days. And then this program that we often use, and we often use them because they treat both the mental health and the AODA predominantly, whether people want to believe it or not, that there's both. You know, so they have the ability to treat both, which I personally think is the most effective way of doing so. But I lost my train of thought of where I was going with that.
Thank you.
Re-ask the question.
The question was what determines the
Oh,
length
yeah.
of their stay?
Yeah, so then they're constantly doing the assessment and
Okay.
determining, and then I know where I was going. This program, they do have like a step down program, so we have someone that has been there for a few months. They've completed the 90 days, and on rare occasion, we get where they're doing super well, and they work with them on getting jobs, finding homes, and things, because we do have people who end up in Kewaunee County, not because their support systems are in Kewaunee County. You know, they may have come here for friends, they may have come here for significant others, things go awry, and then they're left with nothing. So it's a program also that we pay $10 a day more for, but they'll connect them to community employment, they'll connect them to housing resources. And so to me, it's worth the $10 because if they can become productive citizens of a community, that's gonna mean a lot.
Thank you.
Yes.
So, I know two people well, more than two people that were severe alcoholics, but two of them who have been through these 28 days or 90-day programs numerous times. One of them is since deceased. One is a younger relative who has been through probably the 90-day programs during his lifetime. I would say maybe 20 times.
Mhm.
And he just thrives there. He does so well, and he's a very educated person. And he hasn't worked for many years, even though he's in his 50s, but he was in management. And I always would say to his ex-wife, you know, if he could just stay there and have some type of a job there, then he could keep functioning. But his normal time out of a program, even in 90 days, is like 11 days, and he's like back to drinking. Within 2 weeks, he's back to drinking. And so I've known this person for 20 years, and this has been a cycle.
Yes, and unfortunately, what happens oftentimes is people will go to a treatment facility, they'll do very well in the treatment facility, but then they go back home to the same friends, the same, you know, problems that they have, and if they don't have the ability to manage some of that stuff, it's gonna increase the risk of relapse.
If I may, what you're also seeing from some of the data is it's about structure. In that if they're in a program, they're structured and they have to follow this and someone else is kind of doing the monitoring. Once they have to go to self-monitoring, that's where the trouble comes in, and we see that, and you see that a lot of times with your really high dollar folks, is that they'll do okay if they're in a structured program. Why? Because there's that monitoring, there's always that checking in. But then once they're out, they don't have that oversight, they don't have that monitoring anymore, which therefore is the temptation to go back.
And so we have, we try to work really closely with, if we have someone go to the facility, so then when they transition out of that, they're back in our care. So they're back in, maybe it's our group programming, maybe it's our, so then we can kind of step them down from going to that structure, that significant amount of treatment to nothing, that we're providing them that step down to help support them with the goal of always kind of, weaning them off and eventually, hopefully no longer needing it. But some people need it the rest of their life. No different than I'll use diabetes. You don't just treat diabetes once, you have it for the rest of your life. Addiction will always be there. The goal is you can recover, but recovery is a process. Recovery, you will relapse, you will have things happen, but the hope is then every time you do relapse, you get back on the horse a lot quicker and it's not as devastating as the time before. So the rule, the state statute for our alcohol and drug programs has been rewritten and will go into effect on October 1st. So some of the things, some of the process of updating all of our programmatic policies and procedures and getting us so that we'll be up to speed as soon as October 1 hits. There'll be some changes that may be noticeable, some changes that are not. One of the big things is that there's strong encouragement to be a smoke-free environment. Now, we do have county ordinances, but people smoke outside. So I'm hopeful to be able to, and the logic behind it is smoking and substance use frequently go together. So when someone walks through the door, they see people smoking or they smell cigarette smoke, that's a trigger to them using. So it can be a trigger to lots of things. So the logic is let's eliminate the triggers so when people are coming here, they don't have that barrier. So one of our hopes is that we work on eliminating the smoking on the grounds here, because it's easy for people just to go stand outside the door and have a cigarette, and just to get in line, because I could see down the road that becoming something that's required. And there's been a lot of additions related to tobacco, because tobacco is an addiction as well.
Thank you.
Thank you.
I was so longer than my 5 minutes.
It's all okay.
Brian.
Want to get the hot seat?
If you want to do it that way, either way, you can stay where you're at if you like. Unless for some reason, that way you're not on camera. You're the man behind the camera with the money.
Okay, good morning. I'll
Morning, sir.
over the financial report for June, July, here. Starting with the billing report. Okay. For June, we ended up billing $238,000. In July, we are at $165,000 so far. That is still an in progress number. We're running an average of $230,000 for the year. Puts us in about $2,762,000 at the end of the year. So we're in line to be where we need to be for budget on that. Looking at the state aid report, CARS or DHS programs, we have claimed $716,000 through June, and we've received $460,000 through May, otherwise 64%. And for Sparks programs to be the DCF programs, we have claimed $513,000. We've received $366,000, roughly 51% through June. Now, both of these two programs are more back-end loaded towards the end of the year, which means they withhold about, or they give us, in some of the bigger programs, 25 to 35% of the money in the first 6 months, and then the rest comes in and doesn't catch up in the second half. So we will be seeing larger monies come in the months of July, August, September, and then it trickles towards the end of the year. as we've met all our obligations for those allocations. Income maintenance, we have taken in, or we billed out 158,000, and we have taken in 119 through April. We did not get a May payment this year or this month because of an issue with the consortium. So we expect that payment to be coming in September when we get the payments for June. So we should be back on track then. Right now, we're at 75%. So again, that's gonna start trickling into meeting our obligations for all our state programs, but the federal will continue to go on at 50% through the end of the year at whatever we find there. That looks fine. And going on to the contract status report, this is the contracts through or where they are through July payments, which are mainly June payments, so half the year through. So far, where everything looks in line, we have 2 that are red flag that could possibly go over, so we're keeping an eye on those as we get closer to the year end, but we still have ways to go on them. And we did approve a couple more new ones, so they'll be out here next year or next month.
Brian, just a sec, so let's stay on the contract ones for the red flag. Because Dr. Ice is at 94 right now, and I forget, what did we budget for him?
What was contract?
Or is it just by hours, regardless?
It's based on his $400 per hour at his.
So we don't do a dollar amount, or do we know we budgeted for that, or do we not?
It's usually, I think it's working at somewhere around 180,000 in the contract.
Gotcha.
And his contract might also, his payments also include his travel and lodging, so that kind of, depending with him working telehealth versus in the office,
No worries.
It
And
makes,
then the living now one?
that can make a difference in how much we're paying him, so.
Yeah.
But towards the end of the year, we'll see where we're at, and we might have to adjust this contract to make sure it balances.
No worries.
And the other one's Lutheran service, social services, which we could go over by about 5,000.
Is that Lutheran Social Services, or is that the Living Now Counseling? Bad eyes.
My eyes added at, oh, it is living, okay, yeah. Living Now, so again.
I can talk to you about Living Now.
Sure.
Living Now is one of our CCS contracted providers, it's a person of one. We started out with them, not knowing how, it's a new provider, probably on the cautious side of how much that we contracted. Phenomenal provider, doing great work. We've got more people who are seeing him, so that could have had an impact.
And I'll say it this way, Sue, I'm assuming then that if we're putting more work into Living Now, we're probably doing less work with other providers. And so where we're seeing more with, and I guess the reason why I ask this is because if committee members don't ask, well, then I'm gonna ask for them whether they like it or not. Just kidding, but in the respect that they have a better understanding that, okay, sure, we're over with this provider, but that will be made up because we won't be using other providers because we like the work that this one does.
Yes, and Living Now also the CCS provider, so we will get, he only bills for the billable time that he works with them, so we will get reimbursed through Medicaid for the cost of that provider.
Sorry to,
Sorry, sir.
thank you.
Thank you for clarification.
Moving on to the July payments, we had paid out 235,966. The only real noticeable one, or
Oh, I probably had this in wrong order, sorry. So now where he's at is not the monthly, he is at the vendor report one. And so that's the vendor report and the credit cards is next. I apologize, I had them in the wrong order. I'm sorry, Brian.
okay, no problem. The only one of note is we did pay $40,787 to Cholita Institute. Again, this is our monthly payment for the home. So it's another home facility for 2 girls that are being treated in lacrosse. And this will be a monthly Payment going on for at least through the end of the year, and we have it budgeted going into 6 months of next year, so. That's gonna kind of start adding up.
And I'm going to, this is something we haven't seen and I know that, Frank just left, but is this, whose is this? Frank.
This is correct.
This is something that we have not seen in a number of years. But these are what I call budget busters. So you have a single client that's $20,000 a month. We have two, that makes it $40,000 a month. So if we don't, and we're working on it, because again, that's our philosophy, if we were to just leave it in treatment, $40,000 a month is $500,000, basically $500,000 a year. So I just want folks to be aware that a lot of times when these things happen, this is lightning striking. And therefore, by law, we have to provide we have to provide a service. And the service costs what the service costs. So at times when these things happen, they have a profound effect on the budget. And it's not anything that the staff has done. This is what's been in front of us. We need to provide the services, and we're gonna try to work our hardest to get them out of residential treatment, which is so expensive, and provide them other supports that still gives them the services that they need, but at a substantially lower cost. So when Brian brings up the number, which I think we should, but I also want to give the explanation that yes, the cost is the cost, but we are working at trying to get out of it.
I also just want to highlight, this is a situation where this was put in place by a different county and we inherited that. And so I can say probably with a lot of certainty that based on the group of people here, that probably wouldn't have even happened to begin with, because we would have all worked together to figure something different out.
Absolutely.
You know, now we have to figure something out while they're there because that's what we were given. So I think that's why you haven't seen it in many years, because within that unit, because we work very diligently to try to prevent that stuff from happening.
How
Yes,
could you inherit a case from another county, you know? How can they give you this situation?
I know just enough to be
Dangerous?
geez, see what happens when you leave, we start talking about.
I knew it was gonna happen.
We're talking about the two clients that were actually,
Yes.
and I explained about how the cost is the cost, we're trying to work to get them out. Supervisor Swable just asked, how could a county inherit someone else's county's problems?
Well, we have an interagency agreement between human services agencies that do child welfare and youth justice. So in that agreement, we have said, because folks often move, I mean, we're not working with folks who have life management typically figured out. So oftentimes, families are at a trauma stage, so they'll move, they'll get different jobs, they'll do different things, so they'll start with one county and they'll move to another. We've decided as the folks who do child welfare and youth justice that it decreases quality of care when you're constantly, tossing kids around from county to county. Workers change, it can, kids fall through the cracks, gaps can be created, safety issues can be worse than they were if we just left kids with the county they were with. But folks sometimes do legitimately move. And we have decided long ago, predates me, it's a WICSA, the Wisconsin Counties Organization. Julie, maybe you can help me with some of how this all came to be, but it was a long time ago, we decided that 6 months of legitimate residency would allow one county to request a change of venue of a case to another county. So if a family moves and they have a legitimate residence, and not sleeping on a couch, they're not doing, crashing different places or moving around, if they have a legitimate residence that they're renting or someone can show where they are, you then basically send a letter to the new county of residence saying, hey, my client from Brown County, for example, is now living in Kewaunee County. And in 6 months, we intend to transfer that. Of course, this case is an extremely costly case, as we're all looking at, and that sticks out even in a place like Brown County. So They did what they needed to do per that interagency agreement and per the rules and regulations that surround it. And then at month 6, they filed a petition in court. A Brown County judge heard it and said, yeah, Kewaunee County, it's yours. I mean, we protested, we argued it, but really that agreement is set up so that it's a smooth transfer and it's really hard to defeat that agreement because 100 years ago, somebody from my county said, yep, if they move in 6 months, we'll take it. You know, not understanding or having all the factors, you know.
But it's uniform, it's for the most part uniform across counties. The thought is that, you know, if I'm Brown County, this family no longer lives in my county, why am I paying for the services for the family? And therefore, Kewaunee County, they've been in your county now for 6 months, they're now your client. If the other were to happen, it would be the other way around, and things like that happen. So therefore, because of the uniformity, that prevents it from being this whole hodgepodge. Well, they've now been in your county for a week, they're now yours. We've set a kind of a uniform date, and it's understood amongst counties that if they're in your county now in I don't want to call it permanent residence, but a residence for
They can
6 months.
establish residency.
An established residence, then now they are not your client.
6 months from the date of establishing residence.
Bryn, how about dollars? Is there funding that comes back? Is there reimbursement in this situation? And nothing?
This is institutional care, and, you know, there's multiple philosophical reasons I could get into why that's not a reimbursable level of care, but there's all kinds of issues that go with it. So now our challenge is getting them out, but also getting them out safely. Kids don't go to institutions for no reason.
There will be funding to support them once they're out of the institution. That's the purpose of all of our community programs, to keep people out of institutions.
And that's where philosophically, the hope is, well, for counties, out-of-home placement is usually the last vestige where you go, and it's the most expensive. So if it's expensive, that entices the counties to figure out alternate ways to provide services in hospital.
And then there's the human piece of that, and they have children living in an institution, which I'm not okay with. That's not a place where they should be. So, you know, our challenge is getting them out, but safety and the ability to live in the community in a consistent and responsible way with caregivers that are gonna take care of them is sometimes a challenge. That's why. But we'll do that. I will say, my plug for ourselves is that I don't think there was a ton of work done on how we might do that, to get them out before they came to us. So I don't wanna say we're starting from scratch, but we're starting from scratch. So I have all kinds of goals in my head that I won't put out in front of you, but there are goals for doing this and doing it quickly. Money is part of it, you know.
And that's where you weren't there, Corinne, and I had talked about how we haven't had this in years, and part of the reason why, or a large reason why, is because we have a philosophy is that we don't want to send people to out-of-home placement unless it's absolutely necessary, and therefore we try all these other alternatives before being almost forced to do that.
We don't even have an account to put it in, for example. For youth justice youth justice kiddos are typically the ones that go into institutions. I can't remember the last time we had child protection kiddos in an institution.
And how long have you worked for the county?
Almost 20 years, but again, I can rely on Julie to say, I don't know if she can remember putting CPS kids in an institution. So it was just kind of, we were doing budget and we were like, okay, yep, it was in the youth justice budget, and we realized when we were doing budget, we're like, wait, I can't go in youth aids, it's gotta be in, you know, one of our CPS accounts, but literally did not even have a space for this, because it's so foreign to us. And again, I'm not saying incorrect decisions were made, I'm not gonna armchair quarterback something that another worker and another set of folks in another county were doing, that's not my role. But here it's just something we
don't do.
But we'll do it. So, you know, that's my Debbie Downer portion of this. we'll get them going, I'm confident in that, it's just.
I
how
just
we do
wanted
it
the
is-
committee to have more information, so that way,
Thank you.
you know, this is a very large expense, and so therefore I just wanted more information from the committee regarding. I'm sorry, you can continue, Mr. Johnson.
I'll move on to the financial reports that everybody wants. This is for June, using simple math, it's halfway through the year, 50% is our goal for where we should be at budget. Looking at admin, we have revenues at 35% and expenses at 45. Again, money for the DCA or the DHS, DCF money that will be coming in towards the end of the year will hit here in the next few months, and this will be way over budget, I hope, or way over that amount. Economic support at 52.9% for revenues and 47.5% are in line. Children and families, again, this is fringe unit, revenues are at 79.8%. That does include, so far we've received like almost 17,000 in subsidized guardianship payments that we did not have in the budget, and that's going to be an ongoing thing, not just through this year, but next year and ongoing. We hope we work into the budget. Expenditures are at 46.8%, which also this includes a month and a half of the Cholita payments that we just talked about. I suspect that will start driving that number higher than what we budgeted as we go farther into the year. Mental health, or the behavioral health area, we are at 52.6% for revenues and 45.3% for expenditures. Winnebago's been kind of quiet lately, but it's good, that's keeping it down. I don't see any activity in June, hopefully nothing much in July, Sue, or if you're doing. I know you said
There were
something.
people there in
So-
June or July.
Must have been, okay, so we might see a little activity come through, but nothing like 2 years ago when the place was hopping. Looking at the family and community units, they have revenues of 45.5%. Again, some of their stuff more second half of the year funded, mainly CCOP, CST. So we'll expect some more money to start drifting in later in the year on those. And the expenses are holding good at 46.2. Looking overall for the human services financials, we are currently at 666 positive for the year. Looking at 50% again for where we need to be on budget. Our revenues are 47.8. Again, that's some of that state, federal money that's being withheld that will be coming in the next couple months. That will keeping that a little bit lower. And revenues are at 45.8%. So we're in line there. Looking at a year-end estimate, it's still a half court shot, and I'm not going to take it. So too many variables that could change that.
Can I have one more piece to the payment you asked about, from us? I think I was slightly incorrect in the way I answered that. Brian, there is that 3-year average payment reconciliation, so to speak, that will come possibly later, so.
Will that qualify for that? I was gonna ask you. 'cause
I
that's
do
not
think
that
it will.
many days, that's why.
I think it will, I think it qualifies for those 12, so again, there is some percentage of that we may get back in a few years. But right now, still our average is very minimal and very low, so the state has recognized these are catastrophic things, especially for small counties financially. So there is a portion we may get back, but it's not something I would, claim.
And now that is something the state looks at. They get the
Yeah, they do
numbers
that
directly, so
themselves,
it's-
yeah.
we don't even give them the numbers, so they'll look at it and they look at the past 3 years, and it's for the bottom lower counties that are under 40,000.
Yeah, it's for the
So it's
small.
for small
counties.
counties, So if you add a large institutional cost, I think some counties last year did get around 200,000, but they had some pretty good sized bills, so, but,
And we've received some of that before.
and we have.
But it's not the whole thing, but at least they recognize that this is a substantial amount.
Yeah, it's a pot of money that's divided up by all the counties that qualify based off of a formula they use, so it's not anything you can really plan on.
The only reason I was asking that is I didn't know if there was a lag time from when it switches from county, since they initiated it, that the money would be going to them and they'd have to give the money back to Kewaunee County. But in that situation, Brown County is way above that population. So if it's gonna get initiated, Kewaunee County would initiate it. So
And there was a portion of time where they were 30 day, or the inter-county agreement said that you have to maintain, even if you transfer a case, you have to maintain financial responsibility for 60 days to allow counties to plan. Of course, it's much different for a foster care payment than it is for an institutional payment, you really can't plan for that. And then, of course, there are other reimbursements. Speaking hypothetically, sometimes children have different entitlement benefits that they qualify for, like small amounts of social security things, and those all get transferred. So to say there's no reimbursement, maybe it was a bit of a stretch. I could have said there's a little bit.
So as for the month, go ahead.
I just have a, can I ask Brian a question?
Sure.
Backtrack to state aid. Brian, grab the state aid thing. Just, I see we claimed in June 242, May 62, maybe you said, is there just a lag time or were people on vacation and stuff wasn't getting claimed, or what was that? Why is
That is the $192,000 for the family services
Family care.
family care payment we made in June, so that gets to be reported in, part of the BCA dollars is they will cover that. Up to our level of 410,000 or whatever we get with them. So that's why there's a big spike always at that.
I just wanted to share with the committee how I usually read this monthly financial report. I kind of read it backwards. I go from outside in. So what I do is I go to the last page first. I look at basically the year end, which says that our revenues are at 47% for the year and our expenditures are at 45%. I kind of compare that also, and I use that 50% number as a guide. But more importantly, are my revenues above my expenditures? Yes, they are. So there's a positive. Then what I do is I then look at, if you see, we have it by program, but I don't do that first. I do the units. So if you stay on that last page, total family and community services unit. I then look at each unit total. And again, I see that revenues are above expenditures. And again, compare that to the 50%. If, let's say, for some reason that the unit was more upside down, then I would look at specific programs. Because if I look at, again, family and community, though I do it for each of them, then for all those different units, I see two places, the 8521 transportation grant and the bus transportation grant, where expenditures exceed revenues. But honestly, the dollar amounts for those two programs are pretty small. And again, I would much rather look from the larger unit standpoint. But if there's one specific program that is really having an issue, then what I would do is I'd be asking the unit manager, why is that? Because they would be able to provide a better explanation. Let's say that Corinne's was more upside down. Well, we have the Cholita payment of $40,000 a month. Oh, okay, I now understand. I just wanted to share with the committee kind of how I kind of go backwards and go outside in. But as you're seeing, our staff's doing a phenomenal job with regarding to budget, even with Cholita coming in here and those types of things. So I just wanted to share how I kind of look at things and then really commend staff again on doing a fantastic job of managing their units and their budgets. So. Was the credit card and the credit card, was that all as part of the vendor payments?
I usually just, yeah, it's
So,
out there.
okay.
So,
Okay.
Anybody have questions and any clarifications?
Any questions for Brian? Service director.
All right, two things. Some may not know, I didn't want to bring it forward to the committee until I knew that I had approval from the executive committee. I know that human services is the, for sure in money and then in manpower, if it's not the largest, it's one of the largest departments in our county. And I have served as interim director before for a year. But I also know in that year that things were being missed, things were being dropped when it comes to a day-to-day operation. And I didn't want to have the department experience that again. So in previous committees, we've talked about trying to recruit for a human services director. And we did interview a couple candidates and that didn't work out. And the other resumes that I saw, none of them really piqued my interest. So then I had additional conversations with unit managers and then did some of my own kind of reflection. And a couple of the things that have really, that a new human services director needs to have, probably one of the biggest things that I heard from staff is stability. I've been here 7 years, and if we count me as a new person, then we've had 7 new human services directors in 7 years on an average. That's not good for the staff, that's not good for the clients, that's not good for the county. So when I started to think about this, but I also wanted the department to continue to move forward with the changes that I've started to implement, and I think that they've done a great job. So in thinking about how to move forward, I wanted, after looking at the different candidates and thinking about it, I'm going to go in-house. So I asked the executive committee to create a deputy director position. I have informed the committee that if that position is created, that I would be naming Melissa Anoy as our deputy director. I believe that she has the ability and the experience to be able to do that. In that same respect for the committee, what I would like to do is, this is a temporary or interim position. She would be in that position as deputy director until the end of the year. And then it would be my intent to appoint her as human services director. Melissa, how long have you been with the county?
15.
So I don't think she's going anywhere. So I think that will address the stability issue. I think she has the ability. Some of you may ask, well, Scott, why don't you just appoint her now as human services director? And that's a very fair question. And it's my own fear or trepidation, I guess is what I'd like to say, is I want to make sure that we're continuing to move forward with the changes that I'd like. And so therefore, I want to work with Melissa as to going forth with that. Plus, the last thing that I would want to have happen is for her to accept the position and then find out a few months later, this is not for me. Well, then her position as a unit manager would not be filled. And how would we then address that? So to me, this is a great transition that she can work as the deputy director, assisting me in the direction and oversight of the committee, of the department. And then after 6 months, she can take it all over in earnest. And so that appointment or that creation of the position and appointment have been approved, and Melissa started this week or last week?
This past Monday.
This week, so she's already a veteran. So are there questions that anyone may have?
It was approved by the county board?
No, because it's a position, it only needed to be approved by the executive committee. And it's an interim one, but I wasn't going to, by personnel policy, I could have just done it. But I didn't feel that that was the right way to go, so I went through executive committee, but yes, they did approve it, the executive committee did.
Melissa's position now,
Correct,
her department, is she still doing that?
Yes.
Plus the deputy?
correct. And again, part of that reason why is to make sure, here's what my goals and expectations are. And therefore, that gives her, so she does that, and if everything is copacetic, then starting in January, she would no longer be the unit manager of the Family and Community Services. We would then do a recruitment for that position.
Do you have a plan already in the making, so come January first, we're not first scrambling at that point? or-
I believe that Ms. Anoy and I have had discussions of which I'm in favor of, but I am not going to be revealing those because we may find out a month from now that she's just downright sick of me.
Will it take a month?
You know what? I think it will. Why? Because she's extremely patient. Other questions at all on that?
To me, it's to be able to know what you're doing. That's important for Melissa.
Correct.
Know what you're doing.
Well, and we will have regular conversations, and there will be, I don't know that there'll be hiccups, I don't believe that. But there will be some transition into respect that during this time, what are her responsibilities, what are her duties, what are her authorities? And I believe that it will be more of a partnership than specifically one or the other. I think I'm just wanting to continue to express and move forward with things that I would like to see. And one of those really comes down to it is I'd like to see if there's ways that we can track client progress, client satisfaction. I mean, we can talk about providing services, but do we, from a data standpoint, is there a way to track it to show that progression? And if so, I'd like us to be able to do that. And if we're doing that, then be able to provide that to the committee, because ultimately we're responsible for these clients and trying to show that we're providing them services and that they're getting better. But at least as committee, we don't really see any kind of metric that allows us to do that. I'd like to see if that's something we can do.
Thank you, yes.
Other questions on the deputy director position? If not, then I'll go to the 2023 budget. Brian gave me the very first rough draft last night, of which I've only had I had 30 seconds at dinner with my family to kind of see it over my phone. So there will need to be some review and some talk about it. It's a little bit higher than what I would have thought that we would have wanted and what we want to submit. But part of that has to do with some out-of-home placements. Part of that has to do with wages and benefits, and that's where I want to touch base on wages and benefits. And I think Sue nailed it on the head.
Can we whittle it down to one page instead of all of them?
Unfortunately, as for that, we could try. The only problem is the state has all kinds of different programs, so we have to provide that information.
I would love that though, Rose, that would be fantastic.
Yeah, it's kind of like allowance. Here's your $5 spent, just don't spend it all on booze and cigarettes. Yeah, I mean, pretty simple. But
No, because you line up in my program.
exactly. So Sue had talked about, and we already know, and to me, I'm talking Norris County Administrator and Human Services Director, but it's the same. What we're talking about, as people know, is that there is a scarcity, there is a short supply of available workers. And then when we talk about specific programs, there's an even smaller supply of specific types of workers. She talked about an AODA person. So there are a lot of folks that don't have the certifications that Scott Gartsky has. If you ever want to have fun to see when I talk about demand, go to the Wisconsin Counties Association and go to the county jobs listing list. And you'll see the number of folks that are looking for behavioral therapists and case managers and AODA and all these different positions. Kewaunee County is downright, and one of the biggest ones, and again, I'm talking as county administrator, has to do with jailers and dispatchers. Kewaunee County is uniquely blessed that for the most part, we don't have a lot of job vacancies. We don't. But if we're going to continue to have that, we also need to be cognizant of the fact and realize that wages and benefits have a large issue regarding that. So what we've seen is inflation go up. So what was put in the budget for Kewaunee County is we have a policy in Kewaunee County is that the wage that we provide to employees for the next year is the December number of the Wisconsin Employment Relations Committee or Commission. That's WERC. The December number for 2022 was 6.86%. That's the largest number that I've seen at WERC, except for the January number, but that followed it. But that's the largest number that's been on that since I've seen, sort of 10 plus years. But the point is that this is inflation that we haven't seen since the 1980s. So the question comes down to, part of it is that can the county provide a 6.86% increase? As county administrator, we could provide it. I don't know that it would be sustainable. But in that same respect, as now putting my human services director hat on, we also need to be very careful and be very aware of the ability of employees to move on and make more money. They are committed to what they do here. They have been for years, and we have always been, and almost will always be one of the lowest in this region because of our size of county and our tax base of county. But we will definitely be looking and need to be supporting a much larger wage increase than what we've had in the past. Otherwise, we have a definite possibility that people will move on. And if they move on, then we'll have the contract. And if we have the contract, it'd be ironic and serendipitous is that if we were to not be committed to a wage increase and Ms. Norton were to leave, and then because we can't provide the service, we have to contract with her. So we're paying her anyways, plus the additional administrative expense from whomever were the contracting firm that we'd be contracting with. I'm not saying that that's exactly what would happen, but I wouldn't be surprised if that's something that could happen. So in that respect, from a county from a human services director standpoint, I want this committee to be aware that as this department, we're going to try to provide we are going to be asking for the dollars and cents that we need to do our jobs, and honestly, nothing more. And I think that the department has demonstrated its ability and is continuing now that we're on this new path, that we're being financially responsible. We're trying to bill for all of the reimbursements that we can get. Is there an ability for some improvement? Of course there is. But what had happened 3 years ago as opposed to what is happening today is markedly different. And I think as you're seeing with the numbers with Brian, and I think having an accountant has also helped us in our performance. I think that's helped to show and demonstrate the level of commitment that our staff not only has to their clients, but also to the county taxpayers and their dollars. So I'm sorry I got on the soapbox, but I don't really have the exact number yet for the department. The tax levy request will easily be over $1 million. It was the last 2 years. I don't expect that to change. I'm just not exactly sure as a human services director what yet that number will be. Questions that anyone has? Comments that anyone has? Then I am finished, Madam Chair.
Okay. Anything else coming for the committee? Okay, then our next meeting will be September 15th at 8 in the morning. Further comments, I'd like a motion to adjourn. Joanne second, all in favor, say aye.
Aye.
We are adjourned.
And